Hi, everyone. We're going to get started in just a few minutes. Just letting you know if you're around, if two people are around one computer, you just need to make sure you're signed into your own unique Zoom identification, so that way you get your CE certificate. Alicia's going to present. I am positive that's just my type. So go ahead, Alicia, if you want to get started.
Hi, everyone. Thanks for coming to this lecture on blood typing. This is specific to canines and felines. The screen's going to look a little informal, and that's okay. We're going to work through it because we're having some sort of technical difficulty. So, like she said, my name's Alicia. I work at the Blood Donation Center through IndyVet Emergency and Specialty Hospital, where I get to see firsthand the incredible need for veterinary blood products all over the country, as well as some very common misconceptions as far as what blood types to stock up on, which also causes some issues when it comes to the availability of those blood types for patients that actually need them. And it also affects those more common blood types from being able to donate as often as we would like. So there will be no animations. It's all gonna, just be right in front of you. Okay, so what we're gonna cover is what makes us give a transfusion, what determines a blood type, and what it means, what a blood type actually means specific to canine and feline. We're gonna go over some terminology that will allow you to better understand exactly what we're referencing throughout this entire presentation, because this can be a very confusing topic. Once we break those down, you'll see those terms on repeat throughout the presentation. We'll go over the differences between dog and cat blood types. We will talk very briefly on cross-matching and plasma transfusions. Specifically, we're talking here again about blood typing. So we're going to emphasize more on why blood typing affects cross-matching and has an influence in plasma transfusions. So we're going to talk about transfusion reactions, how we handle those specifically as technicians and with referring to our supervising veterinarian, and then we'll conclude on some key points. Okay, so again, sorry this is all presenting to you at one time, but I promise if you hear me and we go along slowly, you should be able to get it all. And then of course we can answer any questions you have at the end. So when do we decide to transfuse? Basically, the best answer and easiest answer is when filling the system with clear fluids just won't be enough. If we have gauged a patient's presentation, condition, or are still assessing underlying matters that have determined that the rate of mortality within the first 24 to 36 hours is very high, it's a great idea to do a transfusion. We also base the decision to do a transfusion on the patient's history and clinical signs, right? What's the patient's mentation? Is the owner telling us that the pet has had a recent or persistent exercise intolerance? Is there a history of underlying disease? This may include cardiovascular or pulmonary disease. Or are we about to diagnose new contributing factors? We, of course, look at our vitals. We've got our basic intake vitals, your mucous membrane color, your capillary refill time, pulse quality, heart rate, and blood pressure. And then we move further into diagnostics. Okay, so getting a little more specific, the general range for a low hematocrit or packed cell volume that will base your decision to do a transfusion is obviously based off of the location of your practice and the preferences of your doctor, but it's very common to see if a hematocrit is less than 20 to 15% respectively, we're going to transfuse. We can also look at the hemoglobin levels plus or minus a lactate. Again, that is at the discretion of your doctor. When we talk about a lactate being plus or minus, lactate is a normal byproduct of the energy use in the body. It helps us measure the degree to which oxygen is being perfused throughout the body. And things that can compromise a lactate reading include stress and even things as simple as a prolonged occlusion when we're trying to draw that patient's blood to get the diagnostics we mentioned before. So this, again, will be ordered at the discretion of your doctor, as it can be influenced and it can be easily influenced. And likely, if your pet's already at the vet, patient's already at the vet, it's probably already pretty stressed. Then we have to consider trauma. Has something happened where the patient is experiencing greater than 20% blood loss? And then we may also have to consider whether this patient is needing surgery, or if during surgery we're experiencing things that are going to tell us we might need to help this pet with vital fluids and blood products. Here's our terminology. So a blood type or group of blood types is determined specifically by antigens found on the surfaces of the red blood cells. An antigen itself, as we know, is any foreign substance that can bind to specific lymphocyte receptors and thus creates an immune response. Okay? The erythrocytes antigens, meaning the antigens that belong on the outside of the red blood cell, are the glycolipids and glycoproteins that play a very important part in the attachment of these antibodies when we decide to transfuse. The presence or absence of these surface antigens determines that pet's blood type, and we'll see some more diagrams on that. Antigenicity describes the ability of a foreign material or an antigen to bind to or interact with the product's final cell-mediated response. This is usually pretty negative. So we'll talk about the level in which different blood types or different groups within common blood types have a higher or lower antigenicity than others. Okay. The antibody is the opposite of our antigen. They work together, complement each other often, and then combat each other equally too. That's a blood protein produced in response to and counteracting that specific antigen. Alloantibodies. These are immune antibodies that are only produced following a new exposure to foreign red blood cell antigens. So if we introduce a new product into this patient's system, we may create alloantibodies, or there may be some naturally occurring. I will go over that again in a little while. Agglutination is important to understand. This is the process of cellular clumping that occurs when an antigen finds that complementary antibody and they bind together, making large clumps and making that product less feasible to flow through a system when it's introduced. Okay, normally not great. DEA, we're going to hear this a lot. That specifically means dog erythrocyte antigen. This is a system of antigens, which then breaks down into groups and then specific antigens themselves. So just like many things in life have a classification, that's the series in which antigen groups are classified. We start large with a system, we have a group within that system, and then we have individual antigens. So while there are presently 8 antigens in the DEA system, we primarily focus on the DEA1 group because it's the most antigenic or antigenic, blood type known or likely to cause a hemolytic reaction. So when we're talking about a hemolytic reaction, we're talking about something that's breaking up this cellular process. Also not good. So this is a really nice chart showing the incidence and presence of the DEA1 groups that I just mentioned within those 8. and the prevalence amongst 75 dogs in the study. So what this is showing here, I hope everyone can see my pointer. The incidence here that we're seeing in this population incidence is breed dependent, and it's always variable, okay? What this is showing is our focus here on the DEA 1.1, 1.2 through 8 here, and then the population incidence in which those were positive in the blood typing, and then whether or not we naturally have an antibody on that cell for this antigen, okay? So as you can see, when I say that this 1.1 and the 1.2 have no natural occurring antibody on the cell, and then each of these also has a significant or insignificant effect on the hemolytic reaction potential. Okay, so on that 1.1 and 1.2 that I just mentioned here, there is a large possibility for an acute hemolytic reaction. Again, that's why we focus on the DEA1 group, because this is the most likely to cause that negative reaction in our patient when we transfuse. Some things to notice here is we have antigens in our body that have natural occurring antibodies against them. So 3, 5, and 7, you see, each have naturally occurring antibodies on that cell. When you look at DEA4, 85 to 100% of this group tested positive for that antigen. That's a lot, okay? And it's very common. Truly, we measure about 95% of the population testing positive for the DEA4 antigen. What this means is that most of your patients, when you type them, are always going to show up for DEA4 positive. If DEA4 positive is the only positive antigen on your typing test, that dog is considered a DEA4 positive only blood type. Some of you may have heard that be called a universal donor, and you will hear me say a couple times that there is no such thing. There is no such thing as a universal blood donor. This is, again, antigen-specific science that is telling us that that receptor, that antigen is on the cell, and we can count on it, okay? The other thing we'll see is that you'll see this DAL group here down at the bottom. What that's showing is that additional dog erythrocyte antigens are being recognized, and that's in this DAL, and I think this is Chi here, specifications. Most commonly, these are mentioned in recent literature amongst Dalmatians and Dobermans, but this again reinforces the need for more precise testing and to ensure compatibility. The DAL antigen here is on its own outside of the DEA group. Okay. When we talk about the DEA antigen group, dogs, we're talking about the DEA1, remember, okay? What this is saying, these are little blood cells. What this is saying is that if a dog is negative for the DEA1, no antibody, okay? If it's positive for the DEA1 antigen, it's got all these little antibodies, okay? And then the DEA4 positive only, remember, that was the only positive out of all of our antigen testing 1 through 7. We specifically group some of those antigens because we are very limited to testing for specific antigens in-house, right? Those are our commercial blood typing kits that limit us, again, to the DEA 1.1 antigen testing. And when we have, All of these antibodies vary according to region and between breeds. We talked about the 8 major groups in the dog, and the anti-DEA1 antibody forms in 3 to 4 days following the transfusion of a DEA1 positive to a DEA1 negative dog. So what that's saying is if we transfused a positive to a negative, because maybe we didn't type, maybe we didn't have it available for whatever reason, there should not be an immune-mediated response. But what that's saying is that in 3 to 4 days, the body will start to naturally create antibodies against that product, right? Because this is naturally unknown to the pet, and therefore the body is going to create that natural response. What this says behind this X is that it says the first transfusion is a freebie, and it's in quotes, and it's got this big X on it, which is supposed to come after you see it. But the common misperception here is that because there's no immune-mediated response immediately when we take a positive to a negative, and this positivity here has also a very low occurrence, people and clinicians and nurses all tend to think that the first transfusion is a freebie and that typing or that cross-matching is not necessarily as necessary anymore. While we have very little chance for this reaction during the first transfusion, we have literature that proves that dogs can still have a negative reaction, and this truly is not the truest. This is a great example, visual example of which way we can transfuse with dogs and how they can accept that product. So we see here we've got a positive to a positive, and then with our negative, which have that lack of that initial antibody response, meaning that we can give this negative to this positive, and then of course a negative to a negative. But as you can see, this is not as flexible as we might like, meaning that there's a lot of chance here for a reaction if we do not type. Cats. Cats are on the A-B system. So they range from A blood type, B blood type, and AB. Okay. This is a solid presentation here of what their blood cells look like as far as that representation according to their blood type. Okay. This is very general because what we're going to talk about is that cats have naturally occurring allo antibodies to their non-self blood type. So if an A-cats have allo antibodies to the B blood type and vice versa. So when we talk about feline blood types within this system, we're actually talking about the more dominant antibody present on that cell's surface. In particular, type B cats that we know are pretty rare have strongly agglutinating and hemolyzing anti-A antibodies. Therefore, if we transfuse a type B cat unknowingly with A blood, we will cause extreme agglutination and a major transfusion reaction that will require that patient to have immediate and intensive care. The recovery process, if we are successful, will not be pretty. Okay. Reports recently say too that if type A cats receive type B blood, they are going to have a less severe hemolytic reaction. Again, remember that those natural allo antibodies are on these cells. So there's potentially going to be some signs of reaction. We'll reemphasize that later. This is relatively less severe, again, with an B to an A. And all of this, though, is patient dependent, and every patient is different. Okay. Some of the more common B-type cats are Abyssinians, Devon Rexes, Persians, British Shorthairs. And then our AB cats actually really only make up 3 to 6% of the feline population in the United States. That's so small. We see some more common AB blood types in, again, Abyssinians, more British Shorthairs, the Devon Rexes is on there again, Persians, Scottish Folds, and Norwegian forest cats. Okay. This is Ray. Ray is a bee donor, which just goes to show that you never know, and that without typing a cat, we run a tremendous risk of putting that patient in danger and needing further care, further expense, further stress. So here's your, common domestic short hair bee blood type, and we would have not known had we not taken the time to use some of our methods and techniques. Okay, he's cute. This is another visual for the cats. Here we see that, again, we can give the AA and an A to an AB because of those less naturally occurring alloantibodies. AB to AB, of course, and nothing else. And then a B to a B, okay? These are some great examples of the more common blood types tests we see in clinicals right now. Specifically, these are the agglutination cards, the rapid vets, and then the Alvedia typing tests. So this specifically here, the Alvedia test, is providing us with an immunochromatographic visual, and it's telling us the type based off of the response from the donor's blood. Okay. The agglutination card is telling us a similar thing with a different technique. This is simply just saline, as we know, mixed with the patient's blood, just a couple drops. If we see agglutination here, we know that that is going to cause an issue. Right. So we would want to transfuse this. This nice diffuse spread here of cells is a great positive reaction. Okay. The old technique here is the old cell washing tube method. This is pretty outdated. It can be pretty technical. I haven't heard of a lot of clinics or clinicians using this method anymore, but it does still exist. And it is important to, again, recognize that this smooth suspension of red blood cells is a negative result. So this here is slightly opposite of that. What's nice about these Alvedia typing tests here is that we can still get a blood type result even if the patient is naturally agglutinating or experiencing, major hemolysis. These agglutination cards did not used to allow us to do that. So if you had a patient with severe IMHA where it's requiring large amounts of blood and basically at the same pace that the patient is destroying those cells because of its condition, we used to not have much choice other than to just give that pet blood and hope that we could stabilize it without causing too much of an interference with the body's natural system. And again, this was while the dog was destroying these cells almost as quickly as we would transfuse them. So it was a pretty high risk situation. We have clearly advanced a lot to where these tests can be more accessible to true results and add a lot of value to the treatment plan that we choose for our patients. We're going to touch a little bit on cross-matching. Cross-matching means that we're now testing the compatibility of the unit that we've typed to the patient. Because again, just because we typed it doesn't mean that if we give it a bag of that type of blood that it's not going to have an immune response. When should we consider a cross match? If we don't know the transfusion history, if we don't know the DEA status, so specifically typing it, is this the second transfusion? What did we give first? The reason this is important is because, like I mentioned before, within time after that first transfusion, if the blood type is not necessarily matching, the body is going to produce those natural antibodies, which are then going to create a different response. So if we don't know that the patient was compatible for its first bag of blood, and this is the second transfusion, was the transfusion more than 4 days ago, like it says at the bottom there, we could be causing a major issue, as well as adding additional antibody antigen reactions that were never supposed to be there. If we know that the patient had a history of previous transfusion reactions, we should type. Okay. If the first transfusion was more than 4 days ago, like I said, we have now created a route without typing to create antibodies, and then further the opportunity for a negative response in the recipient. And like I explained, this leads to the formation of anti-DEA1 antibodies that are going to cause that negative result. The other consideration is, do you have a cat? If your patient is a cat, you should always type and cross match. As we said, those natural antibodies exist for both types on the cell. And remember that if a B cat gets A blood, we are in big trouble. Okay. Hopefully everyone recognizes this reference. It would have been so much more emotional if my animations were working. Always type and cross match your feline patients. When we break down the types of cross match, it's pretty important to know the difference between a major and a minor, because a major cross match can play a huge role if you have to give a patient plasma, or if you have to give a patient plasma after a transfusion. Okay. A major cross match is taking the serum from the recipient and testing it against the red blood cells from the donor. Okay. Basically, we're taking the serum, seeing if those antibodies on these red blood cells are going to respond to what we're putting into it. Okay. The minor cross match switches it. It needs the serum from the donor and the red blood cells from the recipient. This detects whether antibodies in the donor serum are going to affect the red blood cells that we're about to transfuse. Again, we need serum from the donor and the red blood cells from the recipient. The criticalist from our hospital phrases it best, I think, where she says cross-matching bridges the gap between the lack of complete commercial typing, because again, remember that we are limited to DEA1 typing in our clinics, and more advanced typing through all of those other groups that I mentioned before can be performed at other specialized blood processing centers like Animal Blood Resources. So this bridges the gap between the lack of complete commercial typing and screening for potential transfusion reactions when unidentified antigens may still be present. Okay. Plasma. Plasma is an entirely different topic, but I did want to touch on why typing would be important here and certain situations where this may be really applicable. There is a lot of concern over the type of plasma you put into your patient, and that may or may not be misunderstood. Okay. When we're considering using blood products, Do we need to use some or all of the components? As we know, we can start with a bag of whole blood, and we can then break that down into numerous components, whether it's packed red blood cells and plasma, fresh frozen plasma, cryoprecipitate, all of those things. When we've assessed our patient, we also need to ask ourselves before the transfusion, do we need some of the components of the blood? Do we need to break that up? Or do we need all of the components? Does this patient need multiple transfusions? And is it a cat? Okay. Again, with cats, we are always going to type and cross match as best as we possibly can. The major cross match comes into play here because it's going to help detect if there will be an immune hemolytic reaction to the donor's plasma. Basically, we're seeing if the donor's cells are going to react in the recipient. And I have a really good photo slide to talk a little bit more about that after there. But then if there are antibodies in this, they will destroy the cells that we are giving. So that major cross match can come in real value. If it's available, if you're about to give a plasma transfusion and you also have the matching bag of packed red blood cells, I realize this is not always feasible, but in some specialty hospitals or a hospital that has regular supply of blood, you may have access to that matching patient's bag of packed red blood cells. Say we're talking fresh frozen plasma here. You can perform these tests with a test strip from that matching bag, or if the matching blood cells are not available, you should basically default to the DEA1 negative for that lack of potential antibody antigen response that we talked about at the very beginning. Knowing exactly what we need and how much of the components we're going to use in the products allows us to potentially transfuse fewer things while avoiding a negative response and slowing the route to the patient's stabilization. Okay, so the more precise we are here with a typing or cross match, the less product we may have to use, the less transfusions this patient may need, and the less stress we're causing to the patient's body and the owner. Okay. Then again, just to reiterate, there's cats. Never forget that we should always type and cross match cats. This photo is a great example of us separating plasma from packed red blood cells that have just been centrifuged at an extremely high speed. What you see here is different examples of what that plasma looks like after it's been spun. So despite the force of centrifugation, you're still seeing a real large presence here of red blood cells. It's pretty hemolyzed. We honestly will not gauge whether we use that unit or not until after it's completely separated from the packed red blood cells, because there's a lot of things that can skew the way this looks. If we find that the bag is not feasible to transfuse, we will toss it. If it's too hemolyzed, if it's too lipemic, these are also things that could potentially cause a negative effect in the patient. So again, if you were able to do a major cross match, you can better tell whether or not any potential cells that are still in this plasma are going to cause a reaction to your recipient. This is a nice clear bag here of plasma. You can see that we use a squeezer and then we squeeze it into specific bags here to separate the plasma. And then this has food for the cells here. This is the same bag. It squeezes real fast. And I wanted to show that this has changed. The color, the representation, everything there. It is very difficult for us to completely separate cells from the fluid portion of the blood. Again, if you have the capability to do a major cross match, you will have a better chance of successfully transfusing one or both products based off of the variability here. Okay. This here, you can actually see a really nice bag of feline plasma. And then, as I said, this one's pretty hemolyzed, a little questionable. Types of reactions. This is also just touching the surface of potential things that we're going to see. And basically, we need to figure out if the reaction is happening due to an immune response or non-immunologic response. So reactions are classified based on the time that they take to occur and the etiology or the cause of them. We have a lot of variables here to consider, and so knowing more about what causes these and what side effects there are can greatly affect your supportive care following a transfusion if there's any concern. So the non-immunologic response is an outside source affecting the efficacy of the transfused cells. This could be a viral disease, this could be parasitic, or it could be bacterial. A real solid example of the bacterial influencers are mycoplasma. These are bacteria on the red blood cells that deplete the immune system. They keep the body from producing more cells. And it's basically like trying to fill a cup that has a small hole in it, okay? If it's immunologic, this is a response within the body where preformed antibodies in the recipient bind to the donor's red blood cells, okay? We also break this down a little further into whether it's acute or delayed. How long did it take for the onset of this reaction to take place? Okay, a delayed response can happen within 3 to 5 days following the transfusion. It's a little scary and something to definitely be considerate of and aware of when monitoring your patient post-transfusion. Okay. Furthermore, is this hemolytic or non-hemolytic? Are we destroying cells? Or is this a type of reaction that is going to affect the body without necessarily destroying the red blood cells that we just gave it? Okay. The most common type of non-hemolytic reaction is the febrile non-hemolytic. It's usually mild. The patient may need monitoring. No matter what, we will always have a dedicated monitor, at least you should, during any type of transfusion. As we know, according to your monitoring sheets, we have specific rates that take place, increase or decrease according to the time in which the transfusion has lasted, how well the patient has tolerated that transfusion, and of course our vitals, okay? No matter what, we'll always have monitoring. If we're finding that the patient gathers a fever, we are going to need to assess other things, as we do, and then the patient may need some IV fluid support too, and that can often be sufficient therapy. An acute hemolytic reaction is an emergency. It requires immediate intensive intervention. Many times we are stopping the transfusion, although each patient is different. Every doctor is different as well. And so they may take you along a different process to assess that and figure out what they need to do next. The signs and symptoms and level of treatment vary depending on the category that the reaction falls in. Okay. How should we respond? Specifically from the nurse's perspective here, we need to tell our doctor. We need to, at a minimum, slow the transfusion down. This, again, is respective. It can be anywhere from 25% to 50% the rate that you're currently going. We will be reassessing vitals and our current parameters at all times and more frequently than maybe we were if we were already 10 minutes into the transfusion. Most commonly, an acute reaction will occur within the first 20 minutes of a transfusion, okay? After that, we need to consider diphenhydramine or Dex-SP. Maybe that was put on board before the transfusion even started. And then in the rare case, do we have a case of anaphylaxis? Most times there, it seems, right, to stop the transfusion. You've already told your doctor. And then in lots of rare cases too, you may need epinephrine. I have not seen an anaphylactic reaction to blood in my time, but I would be interested to talk more with anyone who has experienced that and have some nice discussions there. But all right. In conclusion, so cats always need to be typed and cross-matched. At a minimum, dogs need to be typed, okay? The DEA1 positive blood is a valuable and underutilized resource. If you remember from some of those charts with the representation, that was almost 60% of the canine population. So what we're seeing, especially at the donation center, is common stocking of DEA negative and DEA4 positive only, assuming that those are going to be your universal, or assuming that it doesn't have the same potential to cause a reaction, which is not true at all. And I hope that any further education on this encourages people to at least type their patients, cross-match if they're cat, and truly consider too the effects that stocking up on inappropriate blood types has on the other process of blood banking, blood donation availability, and the need around the country. Typing is quick, it's simple. It allows our donation center and other voluntary centers to accept all donors, regardless of their blood type, instead of having to turn away a positive donor because we have too much or because the need isn't as present. It's not necessarily true, and we can definitely be a lot better in that. We offer more precise medicine as professionals when we type our patients. We also allow a greater availability of that negative and DEA4 positive blood for the patients who actually need it. This is Gloria. Gloria is telling you to sign your pet up today to be a blood donor. Locally, you can do some research. We are working on getting more profile bases so that people can search local pet donation centers near them and have resources closer to home rather than feeling as though they have to travel a long distance to do such a good service. I will open it up to questions in the chat, which I think I can still access here. And then I will also provide my email. So if there are questions that I can't necessarily answer right now, there's plenty of resources for discussion on that, and I can easily get back to you.
Thank you, Alicia. Yes, if anybody has any questions, just use the Q&A button and we can answer them now, or she can give you her email and we can chat that way. It's BDC manager at IndyVet.com. If anybody has any questions they want to ask after the presentation. All right. Thank you, Alicia. That was really great.
Thank you to everyone who had patience to watch this a little less formally than we planned. And please, please, please feel free to reach out if there are any questions, if there are any additional comments. We love to chat.
All right. Have a good evening, everybody.
Thank you.